Now, I've got a very lengthy question here, so I'm hoping that my team won't muck around with my question list, and then I'll lose my... No, they've just mucked around it already. So please leave my question list alone for the moment. I need to read through this one. It's anonymous. It is a lady who says that she felt that in a previous webinar that you've done, you seem to feel very much that the patient has all the rights and the chiropractor none. The GCC's job is one of regulation, gave the impression that meant protecting the patients from chiropractors. But this, she felt, was dismissive of female chiropractors working alone. Chiropractors must discuss in detail the reasons for discontinuing treatment for a patient and or denying treatment in the first place. So a female chiropractor, alone in a building with a male patient who is enjoying her discomfort or fear, must sit down and tell him that this is a problem and expect him to leave. She points out that one of the common responses to a woman being raped is to freeze, with all the subsequent issues with the legal system should the woman be brave or foolhardy enough to make a complaint, and with feelings of personal guilt. She says, we have just done a cycle of compulsory EDI training, and yet the GCC seem unaware of the women within the profession and their needs. Now, okay, she's not neglecting the fact that men can also be in this situation, but women are more commonly. She's got some other points in here, I think. She is a relatively small and she's upper middle-aged lady. I can say that because she's younger than me. And she's got 20 experience, no complaints. She says it's a sensible precaution to only offer new male patients daytime appointments when other people are in the building and within shouting distance. Of course, that must be, if it makes her feel comfortable, that must make for better treatment, I'd have thought. If a patient makes me feel uncomfortable, she says, which has happened a handful of times over the years, and it's been very, very scary, she's suggested to them she's not the right person for their problem and referred them to a male practitioner with the consequent minor risk to her reputation. So how do you respond to that? The nub of it is, how free is a female practitioner to say to a person, you need to see someone else, without having to go into detail why?
I recognise this as a very challenging issue. I don't recall kind of alluding to this or covering this topic in any of the webinars. It might be implicit in something I said, but it was not my intention to dismiss anything in relation to that. It's tough, isn't it?
It is very. Yeah.
Being a lone practitioner is a difficult place to be, it seems to me, not one I have any experience of. And the clinician is made vulnerable by their circumstances.
Yes.
And I haven't got any, offhand responses about what to do. But this has come up in the consultation on the code of practice. It came up at some of the webinars about cessation of practice. And there's somehow a belief that you can't end the arrangement with the patient for fear that the GCC will be on your back.
Right.
I think our position is that it is for the clinician to determine what's the therapeutic relationship.
Right.
And to be able to discuss that in collaboration. That's the new principle, in collaboration with the patient.
The new principle as in the code that's not yet approved.
That's right.
So,
well, there is already stuff in the code about, discussing with patients.
Yes,
and needs
exactly,
and so
discussing
on and so
with the
forth.
patient.
But this kind of emphasises that therapeutic relationship in a wider way. So
I think
I haven't got any pearls of wisdom on this, other than that it is absolutely for the practitioner to work with the patient as far as possible.
Yes.
But of course, when it comes to personal safety, that has to take priority.